Going on. So are we live?
We are
All
here.
right. Well, welcome to the Maine Recovery Council meeting. Thank you all in public and on Zoom that are joining the council members today, and thank you for your support and interest in the work that we do. I have a couple of things to announce. One is, I just want to know, and I just double checked, congratulations is ordered to Representative Kraft, who just made Social Worker of the Year in Maine. Accomplishment of a council member. And I also want to recognize that today, October 10th, is World Mental Health Day. And so it's important that we recognize both the people with mental health disorders as well as the people who work in the field and honor them and continually make aware of people who are struggling with mental health issues and being able to work and ensure that they get the treatment and help that they need. So just an awareness that is today. So my name is Pat Kimmel. I am the chair. We have a quorum for our meeting. I ask that members please remember that sometimes on Zoom, you can't always hear, so speak up, and you also can't hear, so say who you are speaking so that they know that, and we'll do our best. And we have Tina on Zoom and Chastity on Zoom. I think that's it. Yeah. Tina, all right. And we do have an activity that part of what Kim will do, and we'll explain when you need to be part of that. We may ask you to write something in the chat so that we can make it part of the discussion for our members. So I think that is it. So as I shared with you on the email earlier, we have a really tight meeting. And so there's a lot on the agenda, there's a lot to accomplish, so we're going to try to get it all done. And it's really refreshing. As stuck as I felt last 2 meetings, I am feeling absolutely just excited about the projects that are moving forward here. And so for that, we will move on because we've got a lot here. So the first item on the agenda is review the minutes of September 14th. You all should have received a copy in the email, plus it's posted on our website. Do I have any questions or concerns in regard to the minutes of September 14th? If not, I entertain a motion.
I make a motion to accept the minutes.
Miles made a motion. Do I hear a second? Representative Kraft made a second. And because we have members on Zoom, we have to do a roll call. Can you call a roll, please?
Yes, I can. Liz Blackwell-Moore. Todd Brackett.
Yes.
Lydia Crafts.
Yes.
Joseph Everett.
Yes.
Betsy Fitzgerald.
Yes.
Courtney Gary Allen.
Yes.
Pat Kimball.
Yes.
Ben Mann.
Yes.
Bruce Nodden. Miles Olet.
Yes.
Eric Small. Gordon Smith.
Yes.
Keenan Thacker.
Yes.
Chastity Toole.
Yes.
And Paul Benzel.
Yes.
All right, motion carries. Thank you very much. So the executive committee met and we reviewed the contract, made a few changes in it that the committee had requested, and we have hired Dr. Kim Johnson, and she is on board and ready to roll. And I've given her an hour and a half to do a presentation. So I'm going to turn the meeting over to Kim. Thanks.
I'm not going to talk for an hour and a half, I swear. I hope that I'm only talking a little bit. I have 3 things that I'm hoping we can do in this hour and a half. And the first is identify the goals of the effort. As I was doing the data analysis and data collection, it occurred to me that I was making assumptions about what you were trying to accomplish. And I have continued to make those assumptions, and perhaps it's not a good idea. So I thought we could start with coming to some agreement on what we're trying to achieve in the short term, and I'll get to that in a minute. And then everything that we do, everything you do with me anyway, after that will be focused on that specific goal. So I want to share my initial data scan, and that's when I'll do the most talking, and then I wanted to facilitate the beginning of the discussion of your priorities. I think that will carry into the next meeting. And you'll have some more stuff. I think Ben's going to present some stuff next month, and so then you'll have, and I'll have some more data next month, and so I think you'll have a lot of what you need to make some decisions by next month. So here's what I would like to do. I'm going to pass out these papers, and you just need one. Pass in that direction. And what I would like us to do is to think about. And I picked a time frame, and so if you don't like the time frame I picked, you can argue with me about that, but I felt like the purpose that we were starting with was something relatively short-term to get us rolling, right? And that there will be a sort of longer process to identify longer-term goals and longer-term strategic planning. But that what I was hired for was basically to come up with help you come up with a short-term plan. So I picked a date of December 31st, 2025. You can tell me that you don't like that. But I just wanted to kind of get things moving from that perspective. And I thought what I was thinking that you could do is everyone on your piece of paper and on the Zoom people, write this down in the chat, and I'm going to have you say it out loud, is to talk about what you want to accomplish with your funding decisions in the short term over the next 2 years, which will really be not that long when you think about the process of giving out money. So in the way to frame it is, that I want you to frame it is, you're going to increase or decrease something by a number or a percent, and then I put in the date by December 31st, 2025. If you hate that, you can change it. And so some examples I put up just so you can think about the format, and these are not things that I think are your goals. These are things that I expect won't be your goals, but they just are, framed as the way that I think we should think about it. So the first one is we'll increase the number of affordable housing units by 100 by the end of 2025. That's just an example. Or something like we will decrease the number of children in out-of-home placements by 5% by December 31st, 2025. So that's the format. Like, what is it you're trying to accomplish? I had something in my mind, and I'm sort of hoping that you get somewhere around that place, because otherwise I have to sort of rethink what I'm trying to do with you. But I want to make sure that I'm on the right page and that we're all on the right page. So do you have questions about that? Anybody? So
One each?
just one. Your one goal, what the primary thing that you think we should be accomplishing with this funding.
Got it.
In the next 2 years. And I'll only give you a short period of time. I want you to use quick thinking, not long thinking. Maybe 3 minutes. Yeah.
Someone may have asked, but is this anonymous? Do we put our names on these?
Oh, no, it's not gonna be anonymous, you're gonna
No.
announce it to the group.
All right.
She's gonna shame you.
No shame. But thank you for asking, that was a good question.
No problem.
I was thinking the same thing, Miles. It's like sharing your vote.
Does anyone need more time, or is everyone good? Are we good? Okay, so here's what I would like you to do, I guess the rules of the game. So we're gonna go around, and maybe we should do roll call. We'll go around the group, and you're gonna say what's on your paper, and then put it up, or just pick a whiteboard on that whiteboard. Now, two other rules to this is, if somebody else has already said what you said, you don't have to put it up, just say, I agree with whomever it is, right? So, and the second rule is, if you decide that somebody else, when somebody else has said their thing like that, oh, that was way better than my idea, you can pass and just say, I like so-and-so's, right? So we don't have to have, how many people do we have now, 12? We don't have to have 12 different pieces of paper up there. If you all agree with one, we could wind up with one. What we're gonna do at the end is, with however many are up there, I brought my sticky, my smiley faces, and we're gonna vote. We're gonna pick one. And let me just say before we get into that, this is an initial goal, right? Goals shift and change as the world shifts and change, and as you learn more and as things evolve. But having a goal is really important, and your having a goal will help me figure out what you need to help you reach that goal in terms of information. So don't worry about like if it's perfect or not, okay? All right?
Guys, just so I'm clear, is your idea that we're getting to just one goal?
Goal can have multiple things.
Yeah.
Okay.
So maybe it's higher level than you were thinking, I don't know. Let's see what people come up with, and we'll see how that goes. Shall we just go around? Yeah, thanks.
For the purposes of the public that may be watching online and for the recording, it would be helpful if somebody could read out.
Everyone's gonna read out their own.
Great.
So who wants to go first? Yes.
Paul Vinsel, decrease the number of overdose deaths by 20%.
Put that on the board.
I can jump in on there. We will decrease the number of fatal overdose deaths by 25%. So I had a little higher goal than that, which would get us to 535 deaths in 2025, which is almost the number of deaths we had in 2020, so.
So go ahead and put it up there, because we can decide if we want to have, how ambitious we want to be.
So I can go, because this is easy. I have the same, decrease overdose deaths by 25%.
So we'll just leave the one up.
I'm just aiming too low.
I was ourselves by putting two that are the same up there.
So I had reduced overdose deaths by 50%.
Wow.
Whoa.
I had crossed out 35.
I almost went there, Lydia, but.
Excellent.
Anybody else? So I want everybody to have a say. So let's just go around the room. And if you agree with one, that's fine. Just say, I agree with, one, whatever's up there, or just,
So this seems huge. So mine was, I was writing on my priorities, is to increase the number of MUD prescribers. And I don't really have the second percent, but just we need to increase more prescribers.
Okay.
all right.
So yours goes up.
And I mean, in the work, we'll decide by 1%. But
Excellent, Joe.
Well, I'm right up with those guys. I had 35%.
Okay, great.
Todd, it's Todd. So I wasn't really, I'm not sure if I understood the exercise, but I wasn't really focused on overdose deaths, right?
Okay.
So much as, increasing the availability of wraparound services, you know what I mean? Those gaps, there's a bunch of gaps that we see with folks in crisis, who are this, whether it was an overdose situation or whether it was a survived overdose situation or whatever, folks that are coming in and out of our, coming in and out of our system, because I look at it from the justice side of things, but I think on the treatment side of things as well, to fill those gaps, because I think, I don't know how we can reduce overdose deaths if we don't fill some of these gaps. That's where I was trying to go in my mind.
Put it up, because that is actually, that's exactly what I was thinking about in my mind, like, are we all on the same page? Because these different goals mean different things, right? So, who else? Liz?
I mean, I think I agree that ultimately that's a goal of mine, but as well, I put increase preventative supports and resources by 50% for young people and their families that have been most impacted by substance use disorder, which in some ways could be a strategy.
Yeah, right.
But it's longer term.
It could be a strategy, but the group might decide that is, right? The group might decide that increasing the number for prescribers, so it's up to you, and then if that's what you decide, that's a decision, and then I'm gonna have to adjust a little bit too, so who's next?
Could Liz just repeat?
Sure. It was increase preventative supports and resources by 50% for young people and their families who've been most impacted by substance use disorder.
Okay, I'm more on the track of Sheriff Brackett that I'm not focused on the number of overdoses, because it's really how you reduce those overdoses, the interventions. I mean, you've heard us mention before the 1,000 Lives campaign that the professional associations have. We're working on, how they're gonna do that. And so my goal was to increase the number of fully staffed SUD treatment beds that could include detox as well, to the point where there are no waiting lists. And it was my estimate, because you kind of wanted a percentage. We don't have good data on what that would require, but I'm suggesting that it might well require 100% increase, a doubling of the number of beds we have now that are, held for people with substance disorder.
Thank you.
I had the same as Gordon.
Okay, cool.
Kina and Chastity kind of agreed on one that I butchered in trying to write out, but they put that increased funding for low barrier SUD treatment and harm reduction services to ultimately reduce overdose deaths and reduce infectious complications by 90%. And I will get it up on the board, I promise.
Is that they're both the same, or?
Yes, they, Chastity preferred the way Kina worded hers and decided that she would support that, yeah.
So we'll put that on the board.
I would invite Kina to say the name.
Courtney and.
Oh, yeah, she's back, sorry.
Courtney, you
her
went.
video was on.
No, no.
Yeah, so I approach this from like my, how I see the world, which is mostly budget and finance and process. And I wrote, implement a framework to make funding decisions both in the short and long term, and stand-up capacity and to support it. So it's definitely more of a strategy than a goal per se.
So expect nothing less from you.
So do you want it up there as something that we're voting on then, or I'm not sure what you're saying, yes, this is what I want, or?
I don't think anyone's gonna vote against it. I don't think, these are more substantive, this is more process oriented,
Right.
everything on the board is more substantive.
But I think we're stuck there. What Ben wrote was part of our stuck point, so I think it has to go.
Right.
He's going to.
Commit.
Okay, did I miss anybody? Okay, so then I've been debating how many votes to give you, and I think I'm only gonna give you one vote. What? I know, I usually give 3, but I'm only gonna give you one vote. So pick the thing that you think is how do I wanna frame this? I want to say most important. I think let's pick the one that you think we should do. I think, because you want things, I don't want to push you in any direction, I guess. I'm trying to pick the one that you think is the one we should focus on planning for in the next as a goal for the next 2 years.
Remember, that's a goal, and then there's strategies to
Right,
get to the
strategies
goals.
and goals.
Yeah.
It's not clear.
Well, I guess from my perspective, what I hear are some goals and then I hear objectives.
Right.
And so when Sheriff Brackett says wraparound services, I think that would be one of the objectives that would fall under reduce overdose deaths. Right. So in some way, it's like semantics, like what's the big picture? What are we all on board with? And then how does that?
So let me put this way. If we all pick residential beds, or we all pick wraparound, I was trying to think specific, then that's gonna be the goal, right? That we discuss, that's where all the resources will go, and then we talk about how they go there.
I guess I'm sorry, I don't mean to be Miss Process person here, but I guess like we don't have the results of the survey, we haven't had the public comment yet, and I guess I'm, like, these feel like if we chose wraparound support services and we spent all our money there, like, what about all the things we're still waiting for and to know, and like that there's $15 million right now, we don't have to choose one thing for it to go to. I guess I'm just confused on your process, like where we're going
If
here.
you feel that way, you shouldn't vote for that.
What?
If you feel that way, you shouldn't vote for it, right? I mean, so I think if you feel like we should be looking at a bigger, higher level thing, then you should vote for a bigger, higher level thing.
And I agree with that, and I do think we should be looking at a higher thing, but I think there are multiple higher things. I think when you just concentrate on overdose deaths, we will never be doing prevention work. Primary prevention, and in the next 2 years, and I just disagree with that, and so you're forcing my hand into something I don't agree with, but I also think that overdose deaths should be a huge chunk of what we are focusing on, but I don't wanna, if we shut that out of this conversation today, I'm sure we'll never win it back, and I don't wanna do that, I'm not ready for that, just saying.
Okay.
So I see that a little different because goals can change. So if today we set a goal and then we find out something totally different from a survey or from the public forum, you can go back. And goals are, again, for me, and this is just me, are here, and there's your strategies to get there. But a goal for me, it can't be too specific because, well, then you're gonna have multiple goals.
Well, and I think we should have multiple goals. I guess that's where I'm arguing. I think more than one goal would be appropriate in this case with a huge problem like this. If the council does not agree with me, that's fine.
You first, Todd.
I was just gonna ask a clarifying question, maybe of Dr. Kimball. It seems like I'm hearing the same thing, but maybe it's just the way my mind works, right? I hear folks talk about reducing overdose deaths, I hear folks talking about services and, including Liz, early services or whatever type of services. But aren't we all, in other words, I think I would be 100% okay to vote for reducing overdose deaths, because you can't reduce overdose deaths if you don't do these other things. It seems like we're all interconnected here. I don't know how you narrow that into a single goal, but you know what I mean? I don't know how we can do it.
Yeah, I hear you. And I think there are a couple things to that. Well, Courtney, you wanted to say something first before I speak.
I was just gonna say, like, I agree with Liz. I just wanna share that when I read that we were gonna be talking about our priorities, I had a little bit of a reaction because we don't have the public hearing, we don't have the survey, and those are two things that I know I am very committed to, and I think this entire council is very committed to. So I was like really struggling over the weekend, like, how do I make goals? How do I set priorities without all the information available to me? And I don't know that there's anything that we can do about that right this second.
And you won't ever have all the information, right?
No, I don't think I do.
More. Next month we'll have more. And I think we'll continue this conversation next month. I think I do want us to pick a high level goal, which may change.
So I'm kind of stuck too, and I kind of agree with Liz that So like I kind of know what I wrote down as a strategy.
Yeah.
Like the ultimate goal is to reduce lives, and I think there's the whole prevention piece that is really important. So so if we pick, reduce lives, what's that gonna look like in terms of getting into action? So then there's like the next level of conversation. If that's the ultimate goal, then what? So I just don't want it to be like more stuck. Just, we gotta, and Kim, I think you're committed to moving us, but that's the ultimate goal, but it's sort of like what other strategies, and Todd, what you said really resonated around wraparound, and I know from where I sit day to day, people are dying and suffering because they can't get a prescriber. So, but I know that's a strategy, but still it's really important to me.
Yeah.
And
Right, and this is kind of why I wanted to have this discussion a little bit, because I knew different people had different perspectives, and I wanted to be sure that what I'm doing actually serves an end, right? That we are leading to an end. So Cornelius, I hear what you're saying, and I'm trying to think about how to incorporate longer-term goals into the conversation when we're starting with a short-term plan, because that's really what you're asking for.
I guess I'm asking for, well, one, generally speaking, you get to action planning after you've done assessment. Like that's usually, like it goes assessment, planning, then, capacity building, implementation, evaluation. And so we have not completed the assessment phase. And so I understand that we can do things in parallel. So I'm not trying to derail us here. I just know that if we get one goal and it's overdose deaths, which I think should be a goal, but if it's not other things, like there are hundreds of young people who have been completely impacted and their families seriously by this, who will not then what happens? What happens to the work of them that they need immediate relief too? And so I hear you, and it's not just a long-term goal, it's a short-term goal too, because they have immediate needs that are just, that are also require action this minute. And I feel compelled to make sure that we don't leave them off. And I feel like if we have to narrow to this one thing, we're leaving them off the table in the next 2 years, and that worries me. And if the group can tell me you're not gonna do that, and we're gonna figure out some other strategies to make sure they stay on the table in this conversation, I can let it go. But I also feel like just in terms of process, normally you do assessment first, then action planning.
Yeah. And let me speak to that, because absolutely that's the way it's normally done. And usually you have some high level aim, some purpose, right? And maybe that's the way we should be framing this, what's our purpose? Because that defines what you're assessing, right? What am I looking at? So maybe that's a better way of framing it than a goal, because that word seems to trigger some stuff.
And just, I would add sort of, I really enjoyed, maybe you can also weigh in on this, just sort of the way the department laid out sort of the priorities, like its response activities and prevention. So to me, those, we have to have, to your point, Liz, the goals in those camps, like they're important. They're laid out everywhere we look. So I think it's that, and I think that I'm with you, Liz, after you mentioned, when you started talking about your response, that it is sort of both, and that we have to be, there's going to be some prevention and response activities, I think, in the next year and a half.
Okay, so Miles had a comment and
just, Lydia had mentioned it earlier, I think we're diving way too much into this. I think having a main goal of decreasing, it's like writing a treatment plan, having a main goal, and then following down into objectives, which could include prevention, wraparound services, objectives, and then interventions, so I don't know if that's what we're doing, if you're trying to find this main goal, but I think, it's gonna take a few different things, a few different objectives, including, like I said, prevention, withdrawal beds, prescribers, whatever it is that we find that our priorities meet to get to that ultimate end goal.
I think I hear Liz saying that the ultimate end goal is not just reducing overdose deaths, but alleviating the pain that the overdose have caused. Is that a fair reframing of it? No?
I don't know about alleviating the pain, but
I think it's dealing with the impacts of opioids, the problem of the opioid epidemic on families and young people who in 10 years or in 5 years will be the same people who we now are still trying to reduce overdose deaths of if we don't spend the money now on supporting them and their needs this minute.
Or they currently are the young people who are overdosing.
Well, yes, they will get caught in the reducing overdose deaths, I think, under that goal. It's the ones who are not yet in that place who won't get caught in that goal if we keep that as the goal. Paul?
What I heard everyone put as their goal would blend to decrease overdose deaths by December 31, 2025, except for Liz. And Liz's is prevention, which might not have any impact by December 31, 2025, but is also very important. And I think that's really interesting that we all came up with something that would decrease those deaths. So we all kind of had the same idea, except for Liz, and that's probably from where she comes from. So I think that's really important that we put, you know, all the other things, recovery, treatment, or
Harm reduction.
Harm reduction are all ways to decrease deaths, but prevention goes deeper.
And it's a longer term,
Yeah.
it will reduce deaths, but it's a
Yeah.
much longer term
Right.
strategy, right? And the constraint, I put the constraint on with the
Right.
deadline, right? So let's do this. I want to change my plan, if it's okay with you all. So let's do this. So maybe it's the date. And maybe we just, maybe we have two different dates, right? Maybe we have that date, and then maybe we also have a goal that's a longer term goal, which would normally be what we would do, except for we're waiting to hear from a lot of other things, right? So maybe, and again, these will be sort of interim goals, just to keep us moving and make sure that the stuff that I'm doing that you're paying me to do is on track. So let's do this date and pick, I think what I'm hearing is pick a percent that you want to aim for. And then let's also say something about longer term, and I don't know what time frame you want to pick.
I have a suggestion. I wonder if we could tie this goal to the 18-year time frame that we have this money. And Liz, and I'm curious if we said reduce overdose deaths by 25%, it might be a different number, but, and tied it to 18 years from now, prevention might then fall more completely underneath that. Does that
I also
seem
want
right?
something you can measure in the short term, right? Because 18 years, I mean, I'll probably be dead in 18 years.
I won't be here.
I hope
So you
people
want
will.
something to measure in the short term as well, right? So let's pick something for 18 years, so that you have that, right? Like eradicate overdose deaths, or whatever the high level thing, the big thing you want for 18 years. And then we'll also have the short term one, and then our strategies can impact both.
End overdose by, what's 18 years from now? End overdose in Maine by 2024, 2041. 20, and then the time-bound one for the next 2 years is one of the percentages up there.
What are people's feelings about that?
Can you say it again?
The big one is end overdose and fatal overdoses in Maine by 2041.
So eradicate.
Eradicate, there's no more smallpox.
And like polio?
Yes.
Yeah.
And then the time-bound one is reduce overdose deaths by 25%.
We'll vote on the percentage.
Yes.
How's that? All right.
And those are the headlines, that's the headliner? Those are the headline goals?
But the 18-year plan is more than, for me, more than reducing deaths. So in the 2-year plan, if we plan on reducing deaths by 35%. We're hoping that that continues because we got something in place that works. So the 20-year goal would be more, I think, where Liz was going about the quality of life for the families in our kids. So for me, the 18 years or the 20 years isn't about, it's still about reducing deaths, but the 20-year plan should be to say that our families, or however it's worded, have safe communities, or, you know, that kind of thing. But I'm not sure it's reducing overdose deaths, because I'm assuming if we can reduce it by a miracle amount of 35% in 2 years, that would keep rolling over. So what is for me, the 18-year goal is really about a quality of life or eradicating a disease. Well, we know we're not gonna do that, but,
Why not?
we could. I wouldn't be here to see it.
No, we wouldn't be here to see it, but we have eradicated
I mean, me
diseases.
too.
Yeah. All right, you real, okay, what do you want to do?
So let's vote. Oh, go ahead.
No, go ahead, I'm just waiting for you to stay.
Oh, so you have one vote. I took everything down except for the ones that have a percentage. Wait, can we hear what changed? What did that say? Oh, they have, I'm sorry.
Tina's trying to talk.
All right, Tina, here we go.
Oh, it's Kina. Yeah, I was just gonna say, I agree with you, Pat. I think I would also feel more comfortable if we said not just, reducing overdose deaths, but also associated complications. As an ID doc, like we of course always think of overdose deaths, but I'm here at the hospital today and we have very costly infections, that people are dying from. We have the highest rates of acute hepatitis B and C in the nation. So I think that if we can keep a broader goal, that would be great.
Yep, thank you.
So let's first pick the shorter term one, and then we'll have a little bit of discussion on the longer term one. I gave them to everybody but you, Pat. I don't have one.
Is Dr. T's up there? Is Dr. T's up there too?
Yes, I wrote hers.
I took, so
It wasn't.
I don't remember who
No,
this
this is
was.
one I
I took everything down that was not reduce deaths by a certain percentage. So right now, what we're picking is reduce deaths by whatever percent. So you have 35, 25, I forget the other numbers, but they're all up there. So go ahead and look at them up there and put your dots on. Actually, I'll read them so the folks on Zoom know what they're picking.
And Kina, were you suggesting that the associated complications be on this short-term goal as well, correct? Not just on the longer-term goal?
That's my 2 cents.
So so that's another slip.
So you're
So
adding.
it says she wants to add one that says we decrease overdose deaths and decrease associated complications.
It's messing up my process.
Does that sound right?
So you're adding a new one after you added the one already. Let me think if I can allow that to happen. Are people okay with adding that language once we pick the percentage?
Sure.
Yeah.
Okay.
As
so
long
any
as it's
of
still
them.
one, right? And we're adding all that language together?
To one,
To one,
right.
yeah.
Okay, we'll add it after we pick one. Okay. So the percentages are 20, 50, well, that says 52. 20, 50, and 25. But someone had 35.
I think there was a 35.
Yes.
Where's your sticker?
That's
I didn't put up there because it was the same as everybody else's.
Oh, okay.
That's right.
So,
Wait, wasn't Dr. T's like the same thing?
Yeah, I think you got taken
Scroll
down.
up.
This was hers.
I think I said 90%, but that's probably more of a long-term goal. To be honest, I was extrapolating from 90, 90, 90 with our HIV goals in the public health world.
I love that for a goal. Let's see, okay. 20, 25, 35, 50. Okay, let's vote on this one thing. All right.
Just go vote.
Put your dot on whichever one you want.
35, thank you. Thank you.
And folks online, what do you want your dot on? I'll put one on for you.
Push button.
It's on 35%. Chester's not with us right now, so.
That's not a good tool.
You get three, I want to.
I don't like the word. You have to vote for it.
We're missing a sticker, we're not stealing that.
Oh, you get it.
Is that like a hanging chad, Cornette?
Send an email.
It was a weird time.
Well,
It was funny, I was thinking that.
well, we should see. Increase in that, decrease 10 or 10.
Right. Too many voices here.
It does make me feel better, but it doesn't, still is not cool.
Did we get the votes from?
Yeah.
Okay.
Yes, which was 25%, right? Someone covered up 4%. Has everyone voted? Okay, so it looks like 25% got the biggest number of dots, smiley faces. So can Kina, is that Kina? Is she there or is she gone?
She's still there.
She's still.
Kina, can you restate what you want to add to this so we can get it into the record?
Oh, sure, as the overarching goal. I think I left it a little bit vague, but reducing overdose deaths and associated complications, which could include, infectious complications, whatever, interpret how you want.
It also includes prevention.
Yep.
Yeah, we'll have to think about how to measure that and be specific, right? That's the other thing, but we don't have to do that part today. We can just make sure that we're including that it's not just the deaths, but that it's the
Morbidity,
yeah, mortality and morbidity. Yep. Okay. All right. Then we'll end that for now. Do we want to say something about a longer term goal, knowing that we want to it will adapt based on feedback, or do we want to wait until the feedback? I don't want to lose it, but.
Oh, you don't have to worry about that. This group knows me well enough. I will bring it back up.
I think there was enough members who really wanted to keep it open enough that once the survey is completed, and the public comment is come in, that we revisit this and see if it matches that and adjust it from there. I think, and please let me know if I'm wrong, but I think that was the consensus of what I heard.
I think that makes sense.
I'm going to zip through some data. I'll have more next month. There's a lot of things that I wanted to share with you that are not yet in a form that can be publicly shared. Like the cell sizes are too small, things like that. So we're still working on getting you some data that's at a very focused level, but that is shareable publicly. So I'm going to share some things with you. Now, if you remember when I was here last month, I was really thinking that there would be clusters and we could look at clusters. And I will say, at least geographically, that's not really true, and I'm going to show you some pictures of that. The clusters are basically population-based in the state. So where there's population, there are overdose deaths and overdoses. So you can see that from this map. This is at a pretty high level. This is the county level. I think that's 95 going up, and you can see it, the darker colors are the higher numbers. This is numbers, not rates. The higher numbers, so Cumberland County, where the biggest population is, has the highest numbers, and then York, Androscoggin, and Penobscot, which kind of makes sense. And I'll show some other pictures.
And these are fatal overdoses.
These are fatal. Thank you for pointing that out, because I have some that are non-fatal as well. Okay, so can you all see this? My only eyes have to look at my computer. Can you see those numbers? Okay.
Yep.
So this is again fatal deaths. And another way I wanted to look at this So I'm kind of anti-rate, because if you look at rates, and I have slides that have rates, Piscataquis County has a really high rate, but the numbers are so low that even if you got to zero Piscataquis County, you wouldn't really do that much for the numbers in the state. So I thought another way of looking at this was, what are some, are there counties that have higher than the population proportionate deaths than would be expected based on their population? And there are a couple. So if you look at this is from the August monthly report. I don't know, do you all routinely look at those reports? This is from the August monthly report. And if you look at it, Androscoggin and Penobscot County, those have high numbers and a higher percentage of people that die compared to their general populations than the other counties. So Androscoggin has 8% of the population, but 12% of the deaths. Penobscot County has 11% of the population, but 15% of the deaths. And then I also pointed out York, because it's the opposite. It's the one that has the higher, has a lower than expected proportion of the deaths. So it has 16% of the population and 11% of the deaths. So that's one way to think about it. You know, both Androscoggin and Penobscot have high numbers and higher than you would expect proportion of the deaths. So there is data at the township level, and I think it's more informative, but we don't have the maps this month. Because the way we analyze it, it just wasn't shareable. But we will make it shareable next month. We'll either have more, we'll go back further, because that was, the data I shared at the county level is just this year, from January through August. So we'll either go back farther, or we'll suppress more data. Well, I want to figure out what becomes most informative. But the townships with the highest number of fatal overdoses are generally those with the highest population: Portland, Lewiston, Bangor. There's also Sanford and some other small towns that have high numbers. And so I think next month I'd like to share that with you, so you can see a little bit more focus than at the county level. Now this is non-fatal overdoses, and this is from ODMAP. This shows about half of the non-fatal overdoses between the dates that I have when that was run, January 1st and September 22nd. And so this just really also shows it's population-based. If there are places that have a high population and don't have any dots on them, it's probably because that jurisdiction doesn't use ODMAP. Because ODMAP isn't used by everybody, and the numbers are about half of the non-fatal overdoses so far this year. So I just wanted to show you that my desire to have it clustered geographically is just a desire, it wasn't reality.
What are the different colors? What do those represent?
They're numbers of doses that they used for, so that's the naloxone. These are, let me go back, see if I can go backwards. So the colors are about how much naloxone was administered, and I don't have the menu for what that actually is, but that's why there are different colors.
Thank you.
So I asked them to do it a different way in terms of a heat map. And again, it's basically, for the most part, it's the most non-fatal overdoses are where there's the most population: Portland area, Lewiston, Bangor, a little bit in Augusta, and then you see down there, and Sanford is in our county.
Does this incorporate, I mean, it couldn't because they weren't reported, so this doesn't incorporate any non-reported accidental overdose?
Right, and it's only about half of them that are reported, because of the data source.
Thank you.
The data that I could get that isn't from ODMAP is a year old. So it was show you this version that's current, or show you older data, and I thought this would be better, even though it's missing data. And again, so this data is not ODMAP. This is the state EMS data. for non-fatal overdoses. And I want to look at it the same way as I looked at the fatal overdoses for two reasons. One, to see if there's any real differences of fatal versus non-fatal, because maybe some counties are doing really well preventing people from dying even if they overdose. But it really kind of mirrors the fatal one, where Aroostook and Penobscot County have a higher percentage compared to the population than the other counties. And this, again, non-fatal overdoses, and New York has fewer compared to its population.
Sorry, does it say that Aroostook has a higher?
I think it's Androscoggin.
It's Androscoggin.
And Penobscot.
Yeah, it's Androscoggin. It looks, the arrow
It's
is
not
in the middle on my screen than it does on that screen.
Well, Aroostook's the same, 5.5.
Yeah. And I don't know if you already have these in front of you or if you'll get them, but.
You will get them, because we just
Those
have to say.
percentages, right? It just seems odd, like, sorry.
No, which percentages
No, I
do you mean?
misunderstood, no, I get it.
So that's the where in terms of geography. Focusing on population centers, it makes sense, and there's politics around that, and we can talk about that when we talk. So I wanted to look at who's dying. And this one was kind of astounding to me. I mean, this age category. So the 40 to 59-year-old category is the biggest one, and then there's quite a few over 60 too, which was interesting. I think the under 18 is one person. I think that's one death.
Two now.
Two now? Okay.
The 40 to 59, those are the folks who were at the beginning of the opioid crisis, of the opioid. So that's that age range. So if you're wondering why that.
Yeah, I wondered about that.
So those folks, it's not that it's impossible to get painkillers or pills, but it's pretty difficult nowadays.
Right.
Since 2009. So yeah, that would be the age, those folks are.
There was a great article in the Washington Post yesterday that kind of spoke to that very issue in terms of, and this is where I actually think there might be some, in my term, clustering, is I think there are some different groups, and one of them is, and the one that's dying the most is this older group now that probably has an opioid use disorder. But I think I have that a few slides later, because I think that is going to be important. So 70% of the people who died from an overdose in this time period, in 2023, were men. And 90% of them are white, which is lower than the percent of the population in Maine. That's why I think Maine is still around 96% white. But but the other groups are really small. They're just really small because their size in the population is really small, so the numbers are really small. But that is slightly lower than the population in Maine is white. 63% are over age 40. The number of people, the age spread of non-fatal overdoses is a little bit different, and I have some slides on my extra slides that were too busy and I didn't want to share them today, but one thing to think about is that the distribution of people that overdose is slightly different from the distribution in terms of age of the people that die from overdose. So it's something to think about in terms of our plans and who you're targeting. 12% of the people who died were unhoused. I did a rough estimate because we don't really know, but if you take the numbers that the state says of the people who are unhoused, it's about 0.3% of the population. So it's a big difference in terms of percent of people who are unhoused who die compared to the percent of people who are unhoused, as their percentage of the population. And here's another thing, 37% had at least one prior non-fatal overdose. So it's actually smaller than I expected, but it's still relevant because it's a useful intervention point, right?
Well, it's smaller than you expected because it doesn't, it's not an accurate number because it's not picking up people who had a prior overdose, but it was not reported.
Good point.
So it could be wildly underestimated. We always put in the drug data report that when it comes to overdoses where people have not called 911 and it's been what would we call them, Courtney, a private save, we do track those, and some of them get reported back into the system because we have distributed, like we've been the distributing source of the naloxone. But I just think I wouldn't want anybody to look at that number and think it's at all accurate.
Yeah.
There are many people who we lose after they've had 8 or 10 or even more overdoses.
So yeah, maybe this would be better phrased, 37% had at least one prior non-fatal overdose that was responded to by EMS. Right, that gets into that system. And the more we distribute naloxone, the more likely it is that, that people don't get into this data. So, I'm trying to do this as like a journalist would, who, what, where, when, how, why. So as we know, the drugs that have been involved in overdose deaths have evolved, and I wondered where we were here in Maine, and just like most places, almost everybody has fentanyl in their system, or is a cause of death, hardly any heroin. What I thought was really interesting, given my work with other states, is the amount of cocaine and methamphetamine that are involved. It's pretty high. That the cocaine is like Florida, looks like Florida does, which cocaine's always been king in Florida. So really high, and it does differ geographically, which I don't have that data in these presentations, but you see a lot more cocaine in Androscoggin and Cumberland County, and a lot more methamphetamine up in Aroostook County, which has been the case for a really long time, actually. Still a pretty good amount of pharmaceutical opioids, although I'm not sure if there's any tramadol in there, and if you can see the note about tramadol. And there's still some xylazine. Xylazine is, the way I look at xylazine is it's an indicator of how contaminated the drug supply is, like how much that is. So it's not a lot, but it's definitely there, and it looks like it's still growing here compared to last year anyway. The other thing I wanted to say is where, not just geographically, but where do people die, or I asked for the incidence. So there's the location of death, which is frequently the hospital, because that's where it gets called, and then the incidence is where did the overdose happen. So a little over half happened in people's homes. About 14% happened in the hospital one way or another. And then there's a whole bunch of other places. Outdoors was 8%. There were actually 7 or 8 deaths that were in like sober homes or some kind of a living arrangement that's, not treatment, but that's congregate living of some kind. And then there's this other home, which includes friends, probably Airbnbs, and second homes, and it's not really broken out. So anyway, about half, a little over half is in their own home, but a lot in other places.
I have a question on that. Inpatient and ED overdose deaths, are those people that came in ill from the overdose and then died, or did they actually overdose in the ED?
So yeah, I have to go back to the actual original data and look at that to be able to tell you. And I have it, and I could look at it, but let me write that as a note to come back to.
Yeah, it's probably not important from a population standpoint, but from a physician standpoint, that's kind of concerning.
Right. So I'll look that up and let you know. we're taking notes, so hopefully someone will know that.
It's rare that anyone overdoses in the hospital. You'd be in single digits, certainly each year. We know that because our overdose review panel, we're about to come out with our first report from the first 2 years of cases. We don't have jurisdiction over the hospital case. We can't look at a hospital case if the person actually overdosed and died in the hospital. The reason is that goes to licensing and certification. So there's another group of people that look at all those cases, and we just look at a sampling. But we are looking at cases where people died within 30 days of being in a hospital, overdose, because we want to know, well, what happened in that hospital visit, whether it was for an overdose or some other illness. Did anybody talk to them about substance use disorder? We knew that they had that diagnosis. Now that's a difficult one. There was 17% of our cases in 2022 had been in a hospital within 30 days. That's troubling for everybody. So we're getting underneath that a little bit, but no, I mean, I almost know firsthand cases where people actually overdose in the hospital. A couple of cases a year at most.
And Gordon, is that the ED or active inpatient?
No, they usually, the two cases I have personal knowledge of, they were both, I think they were both inpatients. It's usually drugs brought in by visitors, and these are people that are very, very ill and are pretty, they don't want to be dope sick. They're in stages of withdrawal, so their family will bring them in drugs, and it's a very dangerous drug supply. And unless you've got somebody watching them 24/7, it's not that unusual. But it also is, I'd say 1 to 3 cases a year.
Keena has her hand up too.
Dr. Becker.
Keena has her hand up.
Oh, sorry. Thanks. Yeah, I was just going to chime in. Thanks for speaking to that, Gordon. But just on the inpatient side, I will say the research has shown that, up to 40% of folks may use drugs in the hospital. I don't know the overdose data in particular, Gordon. I think you spoke to that, but it is very common and something that we see here. And part of my job is to also, reassure people that people can, stay in the hospital or go home and they'll use drugs if they want to use drugs. So, but yeah, just to say that it's pretty common, at least here at the hospital where I work.
Thank you. So that's what I'm going to share for data today. So just what does it say about your targeted activities? The deaths are distributed mostly by population, but there are a couple counties that stand out as having a higher proportion than the population would dictate. And next month, I was going to say next week, next month, we can look at towns, and that might give you a little bit more detail. The target group, now again, this is with reducing overdose deaths as the goal, is largely middle-aged men. I mean, that's who's dying. So I'm not going to say the 37%, we'll say it's higher than that, so that's a floor. So a lot of people, there's a lot of opportunity, I guess I'll say there. Most people die at home, but a higher than population proportion of than would be expected of decedents are unhoused. So perhaps that's another opportunity. 12% is not a big percentage, but it's big compared to the group. I actually ran the unadjusted. So not age adjusted, but just looking at the proportion of people, and it was over the death rate for people who are unhoused, given the numbers of unhoused people in the state is over 1,000 per 100,000. And fentanyl in combination with stimulants is a large proportion of the deaths, and so that's one of the things when I think about targeting. And deaths is the goal that we're trying to, reducing the deaths is the goal we're trying to achieve, then there may be different groups that have different things that we need to look at. So the middle-aged men who might have an opioid use disorder, It might have a long-term opiate use disorder that started with pain medication, you would want to target them differently, do different things for them and reach out to them in a different way than if they're recreational cocaine users or than if they have stimulant, cocaine or methamphetamine use disorder, right? They require different things. And so one of the things I would like to do is to get a little better sense is, are there 3 groups? Or are there not? Maybe everybody has an opioid use disorder, but maybe they don't. And your treatment is different, your outreach is different if you have a group of 25-year-olds who are weekend cocaine users versus a group of 55-year-olds who have long-term pain medication issues. So I want to dig into that a little bit more for you, but that may be.
The overdose review panel is looking at that.
Are they looking at that?
And the next group of cases they're looking at is largely to see if that very question is that we all worry that with the drug supply being as lethal as it is, how, and there's not much question about what most of the people who die of a fatal overdose have had previously overdosed and are really suffering from, usually over quite a long period of time, from a fairly severe substance use disorder. So then the question is, well, how many might we be losing who just made a bad decision one night and do not have a diagnosis of substance use disorder? And so we're looking at some younger people, but only through that overdose, you really have to really do a pretty deep dive into this person's life to be able to answer that question. But that is what the panel is doing, because we're very interested. I think people worry about that across the country, and I haven't seen a good clinical article on it. What percentage of our people that we lose every year, every month, every day, what percentage of those people do not have a substance use disorder, but made a bad judgment, or maybe that's the other conclusion I've reached.
Right.
Yeah.
That, and there are clues to that, even if we don't do. So we can look at the days of the week, and if there's in ages and the drugs that people are using and the combinations, which won't give us an answer. It just gives clues. Courtney?
I just wanted to say that I have a really novel idea about how we could address particularly people who are unhoused and in city centers. We could follow the lead of Rhode Island and pilot an overdose prevention center. It is the only thing that has ever had a 100% effective rate of keeping people alive in population centers, and particularly people who are unhoused. So I know that that's probably not going to happen in this group, but I feel like I have to say it, that if you actually want to reduce overdose deaths, particularly in unhoused populations, they would stop using alone in tents and dying alone in tents. They would have access to doctors and nurses and recovery coaches and people who can reverse the overdose deaths and get them into treatment and recovery support services. And Rhode Island has already done it, so it's not.
Not done it yet, to be honest.
The council gave $2 million.
But it's not over, they've not done it yet.
There have been some that were unsanctioned that have been researched. And then the results are good for the people that go on a routine basis and use in that place on a routine basis. In Canada, they have actually reduced the death, they think, but they've done a bunch of things. But the Arnold Foundation actually funded a study of one that everyone was sort of an open secret in the United States, and they didn't actually. It was basically the handful of people that went on a routine basis didn't die, but they didn't bring the rate down. The important thing is people have to use it, right? I mean, unsanctioned, quiet, secret is hard to, there's a lot of things about that study. The point is, though, not using alone, right, is the bottom line. Like people who either use alone or who are left alone after they use are more likely to die. And that's probably why you see the 53% at home, right? So I think, we should talk about, like, how do we make, what do we do? What are some things that can happen while the state works through its process to allow a sanctioned site to open? So anyway, a couple things that I think we need to look at.
Kina does have her hand up, sorry.
Oh, I'm sorry, I'm glad someone's watching. Go ahead.
I'm paying attention, I promise. I just wanted to say that I agree with Courtney 100%. And I think these sites have been very well researched around the world, and I visited the sites in Canada. Again, like 0 overdose deaths. And, as an ID doc, I also worry about the morbidity, as I said before, the infections. And we know through modeling studies that they've, been shown to potentially reduce things like HIV, hepatitis, serious skin and soft tissue infections. So everyone probably knows where I stand on this, but I do think that the evidence is there, and it is something that we should consider, at least in the long term.
Yeah, and there may be other ways of addressing that issue in the short term, and that could be something. So,
yeah, sorry, can I just add one more thing, which is we've done studies here in Maine also showing that 90% of our folks who have been admitted to a hospital here with an infection used alone in the prior 30 days, and all of them were interested. Actually, 90%, I would say, were mostly urban areas interested in these sites. Sorry, that's all. I just wanted to put a plug for the Maine data.
That's awesome. I would like to see that.
I would just like to mention something about that, the slide before where you said, what does it say about target activities? I just want to mention, I just want us to be a little bit careful of solely focusing on overdoses as the only problem, because that one of the target group is largely middle-aged men. Like, there are so many women who've been impacted by this, and their children, and many of them end up they're in prisons, they're in different places than men, so they may not be ones that are now, in this last year, have been, maybe overdose deaths, but they've been impacted. And I think our job is to be looking at all those who've been impacted by opioids, and their children have been impacted, and people may have not be using opioids anymore, but their lives have been completely upended. So I guess I just want to caution us of so I know we're going to go back to a long term, but one could be something like the impact of opioids and SUD on individuals, families, and communities, so that we don't lose all these other things that have impacted people.
Yeah, and I think I have heard that, and when I come back next month, I'll have.
Okay, thank you. I will get off the high horse now. Sorry, off the soapbox,
but we've added it to the short-term goal. I think we have to get some more specific, but we've added those issues because so we'll have more information next month on that to see if it can guide us. But that's why I wanted to do that initial exercise, because I was afraid that I was completely focused on one thing that might not be where you all wanted to go. Okay, I want to quickly, I'm going to not do that. I want to share this one last data point with you. This is the monthly number of overdose deaths between January 2020 and August 23. August and July 23 have a lot of pending. So it's the data from the report. But the dotted line is a 6-month moving average to smooth it out a little bit. And it looks like you're already on a downward trend. So, if we picked last year as our starting point, you probably achieved your goal before.
It's 11.5% lower than last year on this day, as of Sunday.
So you're already.
But that's good, but it's still way too many people.
Yes, exactly.
And that's why we don't shout that from the roof. If we challenge it, keep things going up and up, I said, well, no, actually, things are marginally coming down, but, one bad week, one bad month could wipe out that gain. So we really want to wait till we get to the end of the year. We're only 3 months away, and then let's assess.
Yeah.
But it's going in the right direction.
It's going in the right,
But that's only one that just, it's, as Liz said, there's so much more to this than just overdose.
Right. So I we started the conversation about priorities, and I want you to have some time to do that, and I promised Pat that I would stop at 3:30, because you have other business to do. So I'm gonna zip through these next few slides. Do you all have these needs assessments that the state has done? Have you all seen these? Because if you haven't, then I can make sure that you have them for next month. So there's two from PCG, one that were both done for the CDC. One is around primarily substance use, and one was for HIV and overdoses. And then the Cutler Institute did a study for Medicaid. They included more data than just Medicaid, but they did have you all seen those?
No, I have not.
No, okay, so I'll make sure you have them, because I pulled out a bunch of stuff from them. They all have recommendations. A lot of what the state presented to you in July came from these recommendations. I haven't put everything up here. A lot of what they proposed was really the state had to do with how the state needed to do different things. So I pulled out what in my mind are things that you guys could fund. You should have reports, because you might not agree with the things I pulled out. You might think there are other things. So I'm going to zip through this, and then we'll have 10 minutes to talk. But you've already started the conversation. So on the prevention side, they talked about community coalition building and stigma reduction. On the harm reduction side, they talked about mobile services, and this is not mobile methadone, this is mobile other kinds of services. Mobile methadone they did talk about, but in the treatment section. Innovating on syringe services, and I would say this in general, there was a great report written by Rand that came out, I think, this summer. And one of the things they pointed out is, even if we did everything that we have, even if we did enough of everything that we have, we probably would not solve this problem. We really need to innovate. We need to think about better ways to get people into treatment. We need to think about better treatments and better ways of delivering services. And so I would just say, they proposed innovating on syringe services. They had some specific ideas, but probably we need to innovate on a lot of fronts. And they said increase outreach and case management for active users. Treatment, so this gets at some stuff people have already raised, increasing the number of people that are diagnosed with opioid use disorder that receive medication for opioid use disorder. And I would add, we probably need to identify people as well. So the whole 90-90-90, the whole cascade, we're not doing a very good job at identifying people either. So that's my one statement that's a personal statement in this whole thing. So increasing the number of patients that prescribers treat with buprenorphine. Even back when we had the waiver, most waiver physicians were only prescribing to a few people. And most physicians only had the 30-person waiver, which that's typical. But if all of the physicians prescribed to their own patients, then that would be one thing. So, and then actively reducing barriers to access to medication, in particular for opioid use disorder, but I would add, we have other substance use disorders involved here, and so we should be thinking about that. And they had some specific models that they proposed. So I'll go to recovery supports. The central database, I've heard that a couple times, on service availability, expanding recovery residences to locations and populations that are underserved, increasing housing first options and peer supports in emergency departments. On the law enforcement side, replicating programs that are successful, like the Portland Link and the Lincoln County Recovery Collaborative, distributing test strips, addressing participant costs and alternative sentencing, and addressing barriers to participation in the map so that there's, and law enforcement naloxone distribution. And they had some research and data proposals, and most of those really were state government things, but I put these things here. Data collection on hard to reach populations, which really means going out and interviewing people, establishing methods to collect substance use data on young adults, improving data collection on recovery supports, and better data linkage between the various data sources. Okay. So next month, we'll have a lot more time, we'll have a lot more data from the survey, from the hearing, and I'll have some more stuff that will reflect the conversation today. But I thought we could start. I know people have been dying to have this conversation about what are our priorities. So I kind of want to turn the floor over to you all, whoever wants to jump in. Given the information I've shared today, which is not, what's the word I want? It is a small amount of information. What does that make you think about in terms of your priorities? Or maybe you already have priorities that haven't changed given this.
Just curious, and I know we touched on it last meeting, and Dr. Vinzel asked the question, what is everyone's priority? Can we go around the table and just voice it out loud? It's been almost a year, so I just would like to hear where everyone is at.
You want to start?
Yeah.
Next 7 minutes?
Yeah, we can run
Well,
the
let me clarify, Miles. So you only have a few things. So your priority, if you could give me or give the group your one priority and go around, because again, I want to give everybody a fair chance, but I also have business that needs to be tended to. So if you could give me your first priority, and we promise that we will get to the other part, but I think what Miles is asking, he's just curious to see how different we see things and priorities are. So if you could just in a short sentence, give us your one priority.
medication withdrawal beds.
Let's just go around, yeah.
I'm going to refuse to do that because I have a list of 12 things on my paper, and I refuse to narrow it down to one.
I think a priority of mine is another crisis center in the state outside Cumberland County.
Yeah, I have too many. So if you're gonna make me choose one, it's, overdose deaths, number of children removed from SUD, number of people using alternatives to responses, being accessed, return of responses for using SUD. I mean, there's a million. I have too many.
I have a lot, but I'm going to save it today. My priority is families.
Well, for me, we're on the back end of this thing, so, we need to be more prevention, it needs to be earlier intervention, it needs to be, we're chasing a tail.
Mine is the number of employees who can't go to work because they can't get out of their own way.
I think when 50% of our substantiated child abuse claims are involved substance use, that's a real problem in reducing that number so that people have access to the wraparound supports they need and don't have to engage in systems like shared brackets when there are other.
And mine are all sort of, I think prevention, as Liz mentioned, is really important, and then sort of the intervention wait list, so all things wraparound, beds, I love the idea of mobile services. The wait lists are killing us, people are waiting to get services, so just all the services that are outlined in a million places. And I have a long list of those. And I'm in Cumberland County, so I see lots.
If I could do one thing right now, I would multiply the options workers by 10.
Or do you want to?
We're really working hard to double them.
I know.
We will
I'm
do that.
shooting high.
We will do that. I have different priorities for different timeframes. So if you say I have in the short term, I would absolutely agree with Miles, but that for the rest of this year, opening up some of these beds that we're working on, more beds, not just medically withdrawal, supervised withdrawal, but also then a good, sound, staffed residential treatment facility for the person to go to after detox. And then the midterm, strategies would be almost everything. I mean, certainly supporting families, all the services, improving all the services, including outpatient, IOP, and all of that. Eliminating waiting lists, eliminating waiting lists. And then in the long term, really, which to me is kind of the end of the governor's term, you know, kind of midway through our 18 years, somewhere there. I mean, there it really is making sure that there's a really evidence-based prevention program in every community, working with every school. And so, again, priority change depending upon how long I've got to work on it and what resources I have.
Thank you. Chastity? Chastity, you on there?
I am. I have more than one thing, so I can't really name it right now, but I'm struggling with the fact that no one has mentioned harm reduction. Everything is treatment to get people to stop doing stuff and focusing on the family, and that's just something I'm really struggling to hear.
All right, well, you've added your priority as harm reduction, which is great. Kina?
Yeah, I also feel like I have too many to list, but I think just generally speaking, improving low barrier treatment and harm reduction services. There you go, Chastity, got you. And sort of basic needs. Thank you.
Thank you. Courtney?
I was just gonna request that the next meeting is almost solely dedicated to an opportunity to discuss each of these. I feel frustrated right now because I thought that this meeting was gonna be more about what everybody's priorities are, and I made this whole list, and we have 3 minutes to be able to go through whether all of those priorities, so I'm just requesting that we spend a really dedicated amount of time having this conversation at the next meeting.
So, the clarifying thing I would have of you at the next meeting, we were going to discuss both the survey and we were going to what we had from the survey. We were going to discuss things that we learned from the public hearing.
I think that could help.
Add to that, and then Kim had some additional data, as well as we were having a presentation about the budget, which is about really how much money do we have to spend.
So we can incorporate
So
that.
I think we can incorporate, just as you know that I can't dedicate a whole meeting.
So you guys, if you want specific information on the data side, let me know. And
I don't
that's what
want any
said.
more data.
But I will share, because I think I'm being asked to do the analysis of the survey. So I'll share at high level what I can get done in the time before the meeting. That information, you'll have had the public hearing. I think Ben's talking about the budget is going to be critical, right? Because if we're going to talk about the first year spending, then we have to know how much money, and even if you talk about the long-term spending, it's like, well, how much do you really have and how much can you devote to different things? Kind of depends on your purchasing plan, right? So I think we can have that, and we spent a lot of time talking about the aim today, and I think we came up with a short-term aim. We need to rephrase it, and I'll send that out to people. But I think the whole point of the next meeting is exactly what you're saying, is to have the discussion. I have some thoughts about how to frame that to make sure everything gets in. So anyway, I'll think about it some more too, but I do think that is really the point of the next meeting. But we want to make sure you have enough information to make.
That makes sense, and I'm sorry that if it feels like I'm directing this at any one individual. It just feels like I've been told it's the next meetings for a year, and I'm tired.
I'd add, Courtney, like Tuesday, we're gonna meet the program grants committee meeting, and I think that committee's gonna drive, like, you know, when I talked to my list, I was not sliding harm reduction, but maybe on Tuesday, we like kind of drill into the areas.
Right, because you can't say harm reduction and MOUD in one,
right,
when you have one priority, which is why I refuse to say what is my priority, because there's too many to be able to say it in one thing and honor the fact that all of these things need our conversation.
Right, you don't have to find one thing, right? So you have options. So I want to turn it back to Pat, because you have some decisions to make that have to be made this week. And if there are any adjustments that you want to see for next time from what we talked about, people have my contact information. So
I'll make sure that they do.
Yeah, okay, I'm done.
Chastity had to go, but she left one comment about wanting a longer meeting.
I can't read it, can you read it?
It says, can our next meeting be longer since it'll be coming off the public hearing / survey?
That's up to the group to decide if they want it longer than 2 hours. Remember, we started with an hour, and then you said you wanted it an hour and a half. Now it's a regular 2-hour meeting. So I'm just trying to be respectful of people's time, because I think all of you around the table, other than me, have a full-time job. So I need to know the consensus if you want to add more time to your meeting. Again, I am absolutely thrilled, I can't tell you how much, that all of the committees are up and meeting regularly, which is another hour or so out of your time. So I just need to know what the consensus here is, and you can do it by raising hands. Do you want to stay? Question is, do you want to add another half hour to your meeting? I'm just asking a quick raise of hands. 1, 2, 3, 4, 8. I think that means that you're going to add another half hour.
Why only a half hour?
I think that was the request.
No.
So if you want to add more to it, then
No,
go
she
for it.
just said a longer meeting.
Oh, a longer meeting. Oh, well, I don't know why I thought half hour. Okay.
But
So-
for adults, 2.5 hours might be the limit, so maybe it is just a half an hour.
Can we just
Maybe your
do
brain
a
will
poll
go
on
to
an
It may have
extra
been.
hour?
What's that?
Can we just do a poll on an extra hour?
We, fine with the poll on an extra hour. This meeting's separate from the public meeting that we're also
Yes.
having. What's the timing difference? Can you remind me between the two? Is it about, it's a couple, it's at least a week?
Yeah.
So I just want, we want to be able to evaluate what the survey is and distill what we hear as well. So if it's like, yeah, Haley,
Okay,
The
so,
public meeting would be a week before the next,
even if
it'd
it's.
be the first Tuesday
So-
in November.
the agreement was that we extend the meeting. I'm going to ask you quickly by a show of hands, do you want that extended by an hour?
Could I ask a clarifying question?
Sure.
Is this one meeting, like, because of this is just the next
Yeah.
meeting and then?
I'm
we'll go
just
back-
saying one meeting at this point.
Okay, just
There's one meeting extended by an hour, raise your hands. Okay, that motion is going to pass. I'm just doing consensus. And then, do you want the hour, here's the other question, do you want the hour at 1, or do you want the hour to go to 5? Do you want to extend at the top of your meeting or the bottom of your meeting? Anyone who wants the top of the meeting, so we start at 1 instead of 2, raise your hand. 1, 2, 3.
I want whatever she can get.
What's it's the ninth, right?
Wait,
We may have to,
What's on the table next week, or next month, we're meeting
next
for
month,
longer?
we're extending it by an hour, and we don't
Okay.
know whether before or after. The
We'll
one-
see what we can get, and I will get back to you guys,
Okay.
because I gotta check to see
So it'll
if
be
it's
extended by an
available.
hour, we will give you plenty of time so you know whether it's before or after. And one of the questions you may ask is, when is this building officially closed?
5 o'clock. I was literally thrown out of the building at 5 o'clock.
Okay, and I do have to, put everything back after the meeting, so maybe.
So maybe we want to put it, we could do that, all right, 4:30. Okay, so the next meeting will be extended, all right, so let's quickly go through things, and Kim, thank you very much for your time. And Kim actually may be sitting in on a lot of our subcommittees, so it's good to know who we are. All right, so here we
We're
are.
having one Tuesday, if you have, yeah, that's great, perfect.
All right, survey data. Liz and crew have done an amazing job on the survey data. We met as the executive committee and approved that it is being translated into 5 different languages, 6 for $4,500. And we also are using Qualitrix to help collate and get that out. We determined that the executive committee could give the okay on it, but you need to know, we really have no guidelines in how we spend our money and who approves that. So what we're asking at this point is, the executive committee approved it, but we're asking that this council also vote on approving $4,500 for translation and $1,500 for Qualitrix for the survey results.
I'll just jump in on two short things. My understanding is the committee approved spending up to $4,500. If it's lower than that, obviously I think you could approve that. The Qualtrics spending is for an annual account. And so the committee would have that annual account for the year for additional purposes for that platform. And then lastly, just want to point out that if you want to, as chair, you could choose to gather the things that the council needs to vote on and do a bunch of votes at once.
We can do a consensus vote. Yeah.
Except that, yeah.
I just wanted to quickly tell people that the Qualtrics program is a really phenomenal program. It could probably even accept grant applications if that was something that the committee needed or something in the future, but it's a phenomenal, top-notch researching entity.
Okay,
You need a motion?
I need a motion and a second and a vote.
I would move to approve the executive board's recommendation and the amounts read.
Second.
Moved in second. Haley, can you call a quick roll, please?
Yes. Liz Blackmore,
Yes.
Todd Brackett,
Yes.
Lydia Kraus.
Yes.
Joseph Everett,
Yes.
Betsy Fitzgerald,
Yes.
Courtney Gary Allen.
Yes.
Pat Kimball,
Yes.
Ben Mann,
Yes.
Bruce Naughton, Miles Olet,
Yes.
Eric Small, Gordon Smith,
Yes.
Keena Thacker,
Yes.
Chastity Toole, and Paul Vinsel.
And at some point in time, we will have some policies and procedures written in regards to finance and how we do that. But for now, this just makes it so that we have it on record that the full committee approved of those expenses. So thank you very much.
Can I say one quick thing about the survey?
Oh, no, I was gonna, yes,
Oh,
please.
great, okay.
I was just looking for a vote on that
No,
one.
it's great. I just wanted to quickly, while we're on it, I just want to say, I have a wonderful staff person who's working on getting it all into Qualtrics. We should have the translation done today. And she's getting everything in there, and we should be able to have it to you. My hope is by Thursday. And with it, I'm going to send you all a little survey summary that, I don't know if you want to vote on it, but I just feel like the way we're going to disseminate is by us all. It's going to go out through the AGs, through our modes, through the Maine Recovery Council, but then it's really on all of us to send it out to all of our constituents. And my suggestion, and you can take this or leave this, is even to write little blurbs, like if we wanted to go to making sure it was brought up, like, high school students, that we put in a little, like, why do we want your input? I just wrote up a little blurb that people can use about getting, that the survey is to get important information that will help us prioritize the use of the funds here, and then I also put in that piece that's at the top that says sharing your personal contact information is optional. You don't have to answer a question if you don't want to, and you can stop at any time. So that blurb will go with a link, and it's one link. And everybody can get in through one link, but it'll then separate you by if you're answering as an individual, if you're answering as a person within an organization, and if you're answering as a person who works in a municipality or county, or all of the above. And then there's translation links.
So is the intent then that we want it widely distributed to even the public?
Yes.
Everybody, so long, is there any, I would guess that one criteria would be we'd want people to be people who live in Maine.
Yes, it does say people in Maine.
Okay,
So Maine is our criteria.
we send our summit mailing and our webinar mailing to 10,000.
Yeah, great.
But some of them are outside the state, but we'd eliminate them either when we send it or
You know what,
demographically.
Is there an exclusion question?
and you know what I was gonna say,
So
maybe
it might
I
be-
make an exclusion question at the top that says, do you live in Maine?
Yeah, and then just send them right down to the end of the survey if
Okay.
they don't,
If
exclude them right
they
out.
say no, then say,
They can
Okay.
ask for this.
goodbye.
Well, we do ask a question about county and town, but they don't have to answer it, but I think we should have an exclusion right
Yeah,
at the
the way
top.
that Qualtrics works, you could create a question that just kicks them out of the
Right.
survey. They don't answer the rest of the questions if they're not from Maine.
And Liz, you're gonna send this all to the whole.
I will, I'm gonna send it all to you with the link and everything when it's ready, and, yeah, please, sorry, Paul.
I think it would be easy for me to send it to all the people who work at Tri-County or all the people who work at Central Maine Medical Center, but I don't know how to reach other people. I mean, I could go through my email list.
Yeah, and I think many of us, like, it's okay if you don't, because other people, like, you know people you know. I think between, some of us are on, like, there's 10,000 people on recovery lists, people on prevention lists, people are on county municipal lists, so I think we'll do, like, I don't know that you should be too concerned, because I think between the 15 of us, I mean, the idea is that we represent the whole.
Could I put it on Facebook?
Oh, yeah, I
Put the
think
link
so,
on
yeah.
Facebook.
Yeah, I think that's a.
You could also ask the Osteopathic Association
Yeah.
as a member to, if
I mean,
they would be willing to.
As many people as we can do it, and sometimes a personal reach out, and even saying, like, if I send it to somebody, an email, and send them the link, saying, please, can you send it to one other person? And again, everyone around the table touches so many places that I think it'll be great.
Liz,
I have a question.
oh,
Go
sorry.
ahead.
Is it possible could someone fill it out multiple times?
They can.
Do you want that?
I think that if they're filling it out as a different, under different, like as an individual and as a, I mean, mostly they don't need to fill it out as an individual if they're filling it out as an person from an organization or municipality, because their answers will get filtered in.
I'm just concerned about stuff in the ballot box.
You can also create a question in there that, based on IP address,
Right.
they can't fill it out twice.
Okay.
So I mean, I guess they could go to a different computer and do it, but
Right.
please, public, don't do that.
Please. I will figure that out, and if for some reason we can't figure it out, do you mind if I reach out to you?
Yeah.
Okay.
I have two things. So first thing is, maybe we all just write, sorry if you've received this 742 times at the bottom of all of our emails. We just really want you to get this so that we don't have to coordinate who's reaching out to who. The other thing is, it brings up something that's kind of intersectional for me with the next part that we're gonna be talking about, the public hearing. So I wanted to raise something. I talked a lot with Brendan today on the phone. I've had multiple people come to me and multiple different organizations come to me and ask me about the upcoming public hearing and can I help, like, explain the process and meet with, like, particularly there's a group of young people who want to engage with the public hearing, but they were wondering if I could come and explain that process to them. This is something that I do normally, like, this is my role. I feel like very committed to this role in the community, is helping particularly people who have been directly impacted by substance use engage with government or engage with committees or et cetera. But I was having a conflict about my ethical boundaries and whether or not that was ethically okay. And so I talked to Brendan at length about it, and I feel like I'm telling you all that I want to do this work with the community. And the work would be literally, how do you testify at this public hearing? What does that look like? Not engaging in, here's what I want you to say, or here's the priorities that I have. But I just wanted to bring that to you all to make sure that that felt okay, or if you have any feedback on that.
It feels okay to me, Courtney. You sit here, in part, none of us sit here as then I sit here, I suppose, as representatives of the government, but you were chosen, I'm sure, in part by the Attorney General because you are in advocacy. And so it would be odd, I think, to constrain you in something like this, where it's just a matter of we're trying to get opinions. We're trying to get everybody's opinion. And I bet that the conflict that you feel, every one of us might feel. Because I have a whole, kind of widely share it, but I have certain constituencies that I absolutely want to make sure I get it out to, because I think sometimes those are voices that aren't heard. So I would think you shouldn't feel an ethical dilemma about assisting people that have asked you to tell them how can they be effective in their advocacy at that public hearing. That's part of your position that you have with me, ma'am.
Me, it just looks like it's your job.
Yeah.
I mean, that's what you do. You
It's
teach
literally what
people
I do,
to
and I've been like
teach people
really
to
like
advocate.
struggling with it, because I'm like, am I like stuffing the ballot box, or am I just doing the work that I always do?
If you write their speech, yes, but.
I'm not writing speeches, but I am gonna meet with a group of young people who want to be able to come, and I'm probably gonna meet with multiple other groups that want to be here in this conversation too. Okay, thank you all.
And
I go to bed.
actually, if your education helps the process, because they know what to expect, they know what kind of things to be able to say, so I look at it as you're helping the process.
Okay,
So
thank you. I will go to
unless
bed
somebody
feeling
here
fine.
has an objection, no. All right.
It's your job.
Mm-hmm. So, Liz, if you're okay with the survey, and all those have helped, and if you'll be in touch with us with emails and everything else, we will move on to the public hearing.
The survey is going to be completed before the next council meeting, so we're going to send the link, and then people are just going to blast it into the universe.
Yep.
What's the deadline for them to complete it?
Yeah, that's a great, I don't have a deadline on it. Do we want it, I thought it should run, I was thinking originally that it would run at the same time as the open comment period, like as our public hearing, but that's bumping up pretty close to the next meeting. I don't know how much time.
I saw a date somewhere that said the end of the month, right?
Well, right, but that was when the public comment period was gonna be on the 26th.
Could it
So
close
now-
on November, could it close on whatever day the public hearing is?
Yeah, could it close on the 2nd and give you enough time to have a week?
So for something preliminary, yeah, I mean, like the other categories will not be analyzed, but as long as the things are, and I was gonna ask you to see the format before.
Yeah.
So as long as it's just drop down menu and.
It's a pretty normal survey.
Yeah, so as long as it's that.
Very quantitative. Okay.
So the public hearing, I think I heard from the consensus.
November 2nd.
November 2nd, 5 PM?
Is November 2nd, will be the date. It will be, I don't think we've set timeframes yet, but it will be at the University of Augusta in Jewett Hall.
Yep.
And so you will get, we will get you out the details as we get closer, and we'll also send to you things. But I want, and it may just be me, and I think I have a Courtney question here, that using the word public hearing, does that give us a sense of legislative things, or should we be talking about this is a chance for public comment, rather than versus saying it's a public hearing? Because and it's just a legal thing, is it a legal thing that when I put public hearing, that we have to follow certain guidelines legally? Other than that, I'll let it go.
I mean, I'll ask the lawyers that question, but I keep calling it a public hearing because people understand that process well, to an extent. Most people understand that process, and I see it being run like a public hearing, but I'm not. Do you have any thoughts?
As long as
Well, I would defer to legal counsel on that. I mean, it's a great question.
Yeah, I mean, pretty straightforwardly in the bylaws, section 4.2 says at least one meeting each year shall include a public forum in which the council can receive input from stakeholders and the public.
Would you
I like
Public forum.
Okay, so we're gonna make it a
That's
public
It
forum.
does sound
There you
like
go.
we're distinguishing ourselves from the legislature,
Yeah,
and the public
yeah.
forum sounds great.
Yeah, I just don't want
The
to
same rules,
We want
right?
people talking, we don't want.
Oh, yeah, it'll be the same rules, and I'll send you all a list of the rules, and thank you all for giving me comment, yeah.
I'd like input on a couple of features about this.
Yep.
For my office's sake. One is the time frame.
Mhm.
Like, because we do need to, we're talking to Jewett Hall about that.
Mhm.
The other is, to the extent we're encouraging people to submit written comments, and I confess I haven't read, kind of your write-up of rules and stuff about that. Our office will have the obligation to receive those and to process them and to do something with them. And so those are the two things. The first one in particular, I'd really like some feedback from council today about that. The second one is just an issue on a flag that we've talked about and, probably could use some thinking about. So how long?
Quick question, so are we intending that people would be testifying like 3 minutes or less? It'd be, okay, 3 minutes off, and then, but they would be encouraged to submit comments in writing, it's not required, but they could submit comments of any length.
But I would encourage like a one-page, like,
Yeah.
I'm not sure about 1 page, Brendan.
Well,
But
you
but I
have
can
more
understand.
experience with this than I do in terms of this subject matter, but, I do how that's all gonna get worked through and who's gonna do it.
Well, maybe our recovery council coordinator could make us a binder.
Somewhere.
I don't think we need answers right now about the written submissions issue. I'm more interested in a timeframe issue.
Okay, so we can work out the logistics of how the written ones will do, because I think the written ones are gonna be very valuable, because everyone isn't comfortable standing up and saying what they are, so I think so we'll figure out how we can link that, I think, with the recovery coordinator, it's a good use of time with that. Okay, time, did people?
Oh, well, I was just gonna add to the time, if we're talking about an evening meeting, no, okay.
Day.
Like what the expectations are if 400 people show up? Are we pulling a public hearing style for the night?
The question is, if the time restraint, if the university is saying you have to be out of there by 5 o'clock, we have to be out of there by 5 o'clock.
I don't think they are.
But if they don't have restrictions, then we can say, we will sit here until everyone testifies. But we do have to find out if the university has restrictions on that building. And if they have restrictions, we can't say, well, too bad for you, we're gonna stay open. I can't do that.
I know classes go till 9.
I would strongly support 3-minute limit.
Oh, yeah.
Yeah.
Just a little feedback on, if we're doing 3 minutes, it's, it obviously breaks down to about 20 people an hour. You gotta, I think, build in some transition time, so I'd reduce it down to like 15 people an hour.
I would also recommend that we do all in person and then all Zoom, because the transitioning between in person and Zoom is a lot, and
So just real quick,
like
though,
to put the AV stuff on and then transition.
let me just finish my point on that real quick. 15 people an hour for 4 hours is 60 people.
Mhm.
So I don't know part of the question is, what are you anticipating for turnout in terms of volume?
So my thought on that is, and Courtney's more of an expert than me, is that the committee alternate themselves out, rather than stop the conversation. People rotate themselves in and out of the building. And so you don't literally, you could take a break, I guess. My talk was, if you go to a legislative hearing, most of the time, sometimes they take a break because they have issues. Other times, people just get up and move around. That way you can keep it continually going forth.
Yeah, my suggestion would be start at 9 AM. My suggestion would be we're gonna be there until we're done. I don't think that we can turn people away. I think that we should keep it to definitely no more than 3 minutes with a strong chair. And with the expectation in the group norm that if you need to walk away or take a call or go to the bathroom or get yourself something to eat, go do that as a council member.
We do have to have a quorum, right?
Right, to the extension of a quorum, like.
So we have to have.
Yeah.
And I think we can, I think we can use the remote meeting policy to achieve quorum as needed. But I think in that case, we need to, maybe we want to consider council members who are appearing remotely stay on camera, so that they're appearing to be listening.
And as far as Zoom concerned, I think the reason when we looked at those things, it would take 5 in person, 5 on Zoom, that's what, I think it's 5, what was the number we came up with, what was it, 5?
Yeah, we said back and forth, but I think Haley's
The
right.
legislature does it all Zoom and then all in person. I
No.
feel like it moves a lot. Oh, every
It
meeting
goes
I've
back and forth.
testified at, it's all Zoom people at once.
So,
I've only done it
I
in Zoom
mean,
though,
let
so
me
I don't-
just raise, do we not take Zoom?
I thought of that.
Yeah, because.
We're not
you can submit-
required to, right?
And if you can
No,
submit.
we're not really required to do
We
anything,
could-
really.
Well,
But
once a
certainly-
year, we have to
Yeah,
have a
that's
public forum, but we all feel committed to doing this before we put together our spending plan. So, but I guess I meant addressing this to Brendan, that we're not required to do it on a hybrid basis. We could because we could invite people who can't make it in to submit
Yeah,
in writing.
in writing.
I'd say, 5 pages, Brendan.
And the
one.
survey.
But, and they could do the survey, and so, I mean, there is a limit. I mean, we've given people a lot of opportunity here. And I think, again, I worry about people in Machias, and my second favorite town after Lubec. But still, if we give them the chance to send in their comments in writing, honestly, I don't think, this is complicated enough, not knowing how many people we're gonna have. The room's not that big. I don't think we should do hybrid.
So unless I'm looking at the wrong version of the remote meeting policy, I mean, the policy does say, the council shall identify and provide members of the public a meaningful opportunity to attend meetings using remote methods when the council meets either fully remotely or, by hybrid.
well, they can listen, they just, if they want to testify, they either have to send it in writing or be in person. You can still Zoom it.
Yeah, I can
Why
still
don't
send
we just
this.
not allow council members to come in remotely? You're either gonna be there, you can't be there. If you can't be there, you can't be there. That eliminates that clause.
I mean, I think we should live stream it at least so that people can listen.
So they can listen, but if they want to testify, they either have to be in person or send in written testimony, or fill out the survey.
It helps to eliminate the possibility that we'd be here from 9 AM to 9 o'clock at night. And I mean, I don't think honestly, even our most emotional or legislative thing, usually they get resolved as the day goes on. I honestly think it could be done by 5 o'clock, frankly. But part of that is that I just don't think we ought to open it up to Zoom.
Can I just ask for Miles, what do you think? Miles and Betsy, you live farthest away, and Chastity says she doesn't care.
This is important. This
This is not a board meeting, this is about the public hearing.
No, I said important.
Oh, I thought it's an important meeting.
No, I said it's important, so, I know I'm going to be there, and I agree with what everybody's saying. I agree with maybe not letting folks speak via Zoom, just that they're able to watch and send in their testimony or what they have to say via written.
Yeah, because you have time after the hearing, if you want to respond to something you heard, the comment period is open for 10 days afterwards, at least it is with a public hearing. So if we said, if you heard something today, you have an opinion or whatever about, then you still have up until this date to submit it in writing. There's your response time.
Okay,
They can send
so,
anything, wherever.
Yeah.
We have an open inbox as well, right? Like, the public can send anything.
Yeah.
so for the sake of time, because we have some stuff that I really need to talk about, and I know people have places to go. So we're gonna do November 2nd, we're gonna start at 9 o'clock. We will check with the university to see if they have time restraints as far as leaving the building. If they do, we will put that in the public announcement saying that the university is saying the building has to close by a certain time. Other than that, we will stay there as long as people are there.
So I don't think we can just not put an end date on it, because then we're gonna be there till 9 to 5, period, because someone might not be able to only come at 4.
Correct.
So unless we say, so we're there from 9, we need to have like a defined time period for it to be open, I think.
Well, you will as soon as I have the answer to when the building has to close.
Wait, are you saying that we have to put 9 to 5?
Well, I think if we say 9 and until whenever the last people leave, someone might think they could come at 4.
And we'll still be there.
There could be
And
a
we'll
few,
still be
like,
there.
there's
No.
nobody there and the council's just saying no.
Right, no, we leave when the room's empty. That's what the legislature does, right?
But the,
But we don't put an end time,
Yeah,
right? So I think what Ben is saying is, if we're gonna advertise it, there should be a start and an end time for entering, for joining us, even if it goes past that, because otherwise we'd be obligated to stay there that entire time.
How does the legislature do it when they're going to stay until the room's empty? Do they put a time that people have to come in by?
No.
no, just arrival.
and just point out, the legislature has the advantage of not having to rent its rooms. So I need to, like, I gotta give them an end time.
9 to 5.
Nine to five.
I would, well, I wouldn't.
No,
go-
nobody's allowed to sing.
I wouldn't go later than 5. I mean, I might say, 9 to 1 would, and say that, but we will continue until all the people present have testified.
That's a good, yeah.
Yes.
that's-
Okay,
Yeah.
so it's there from 9 to 1, but we can tell the university we may be using the building until 5, or whatever they said.
That eliminates. the
Okay, but we'll
possibility of
tell the
them coming at
public,
4
we're
o'clock,
asking
yeah.
people to come from
And
9
we're
to
sitting
1,
there
but
waiting.
we will stay to hear people's testimony longer if they are there. Make sense, however we word it?
Okay.
All right, consensus?
Yeah.
All right,
What's the name of the building?
Jewett
Jewett
Hall.
Hall. I can send you guys like a map
Yeah.
and like draw a little line to the auditorium. It's like right on your left.
and you'll
when you
get the
walk into
list
Jewett
of the
Hall, but-
rules that I've sent out to people about those prioritized. And also, we'll get out a press release, so the press is done, and I'm working to try to get some, radio time to maybe outreach there, so it's a
And
project.
now that you've all have given me clearance, I'll make a testimony guide.
There you go. That's a good idea. All right, so for the sake of time, I would like to discuss quickly we are down to the 2 finalists for the Recovery Council position. We had 5 total applicants. We narrowed it down, the executive committee narrowed it down to 3. And of those 3, 1 dropped out. So we're down to 2 candidates, which we will interview on Thursday. So here is the question. And I just need a consensus how you want to do this, because again, we don't have any guidelines because we're new. So do you want the executive committee to interview this person, choose between the 2 people, hire them, and then bring the person to a meeting? Or do you want to meet the person yourselves as a full council, and we bring either both candidates before you or the final candidate before you?
I would like you to hire them.
Okay.
I second that.
Yeah, I would like the executive committee to perform that function.
Is that a consensus?
Yes.
Okay.
Okay.
We have a consensus, so there we
Are we
go.
all comfortable with the executive committee, like handling any of the positional details, like start date and? Yes, great.
Okay, and then we'll do an email introduction to her before, and then hopefully, if all goes well, she will maybe be at the public hearing, I don't know, or the public forum, or maybe she will be at our next meeting, depending on when she can start. And I'm saying she because the 2 final candidates are women.
And is everybody else set with us navigating like pay? I think we had a range. Didn't we have a range? in
We
there?
do.
Okay, just take care of everything. Got it.
Pat,
We heard
could you
you.
seek a
All the
mo-
things.
Could you seek a motion on that, please?
I move
Could you seek a motion, please?
Motion to approve the
Oh,
executive committee
okay.
to deal with all tasks revolving around the hiring of the Recovery Council coordinator.
You sit on the executive,
Mhm.
you might want to let somebody else.
I revoke that
I'll make
motion.
the motion as stated.
Okay,
I second.
it's moved, it's been seconded. Is there any other discussion on the hiring process of the recovery coordinator? If not, can you call a roll, please?
Liz Blackwell-Moore.
Yes.
Todd Brackett.
Yes.
Lydia Kraus.
Yes.
Joseph Everett.
Yes.
Betsy Fitzgerald.
Yes.
Courtney Gary Allen.
Yes.
Pat Kimball.
Yes.
Ben Mann.
Yes.
Bruce not in. Miles Olet.
Yes.
Gordon Smith.
Yes.
Tina Thacker,
Yes.
Chastity Toole, Paul Vinsel.
Yes.
Thank you very much. Motion carries. Another quick vote is that, I don't know if all of you know, I think I did email Eric Smith, is not
Eric
going.
Small.
Eric Small. I don't want to say Smith. Eric Small is taking a leave. I don't think he's taking the leave. He just will not be attending until December because he is out of state. And so according to your bylaws, the chair can nominate somebody for an at-large position. And I would like to place a nomination for that at-large position on the executive committee, the name of Gordon Smith.
I think that's a great idea, but are you unappointing Eric?
No.
No,
we
I can have up to
three.
3.
3 at-large members,
Yeah.
and there's only 2 at-large members now.
I'm sorry, did you just make the motion?
I can't.
I can happy to make the motion to.
Make motion, Paul seconded. Any other further discussion about Gordon Smith being
I'd
placed
like
on
to
the
make one comment that I would not be my intention because I wasn't at the meeting of the executive committee. I don't want to be involved with the hiring decision.
That's fine.
So just understand that I'm not going to be part of that process, a couple different reasons. But other than that, I'm more than willing to serve.
Thank you. No other discussion? One more time, call the roll.
Liz Blackmore.
Yes.
Todd Brackett.
Yes.
Lydia Crafts.
Yes.
Joseph Everett.
Yes.
Betsy Fitzgerald.
Yes.
Courtney Gary Ellen.
Yes.
Pat Kimball.
Yes.
Ben Mann.
Yes.
Bruce Naughton. Miles Olet.
Yes.
Eric Small. Gordon Smith.
Abstain.
Tina Thacker.
Yes.
Chastity Toole. Paul Vinsel.
Yep.
All right, all in favor, 1 abstention. Motion carries. Thank you very much and welcome aboard, Gordon. We'll make sure you give you lots of work.
On every committee.
Just real quick to clarify, does that mean Pat, Ben, Courtney
Yeah, I'm not on
are the interview panel? Oh, and Betsy are the interview panel, the 4 of you?
Gordon is not.
No, Ben,
Courtney
Courtney.
is, Ben, Betsy, and myself.
Okay, just so I can make the Zoom send out to you guys.
Yep. Okay, I just wanted to remind people that according to our bylaws, at the December meeting, we have to present to you a list of people nominated for offices. So the governance committee will put those together. You'll be getting some information about nominating people for offices. So you have to have it 30 days before the annual meeting, which your annual meeting is the first meeting of the year, which will be January. So I just wanted to let you all know, and please, you can place people's name in nomination. The governance committee, again, will reach out to people. And if you put somebody's name in nomination for an office, can you please ask them if they want the office before you place their name in there? So I appreciate that. I just wanted to inform you that we were contacted by the Central District for Public Health, and they asked if I would present some of the work of the Recovery Council to their October 26th meeting. I said I would do that. If anyone wants to join me there, let me know. I don't know where it is yet. They haven't told me. All I know is it's on October 26th. So they just wanted to reach out and ask, and I said I would more than willing to do that. All right. Okay. 408. It's a good thing I can talk fast. Any other business that, or questions that you have for this meeting? All right, that was packed jam. I thank you all for your patience. I'm sorry if you were cut off in any way. We just need to get things done. I look forward to the survey, to the public forum, and I wish you all a good evening. Thank you. Meeting adjourned.